I don't like to keep it for so long because these external resorption, they create like an inflammation, and we may have some resorption also of the surrounding bone. And I prefer to extract directly this tooth. Yeah, directly and not way too much because I didn't want to compromise the situation later on. So this is after careful extraction, so we can see clearly the resorption here. And in a case like that, even though the lady had quite already like a good gingival phenotype, I still wanted to make it even a little bit better, especially because, you know, the idea was to replace that tooth later on with an implant. And I did the procedure I showed you, you know, the saddled connective tissue graft. I don't have all the details here, but we've seen that into the movie. And I reused actually the tooth there. And then she continued with the orthodontic treatment for another few months, I think. And finally, we could start the rehabilitation. So this is now here the situation 6 months after I did the socket management. And when we see the occlusal view, I think we can nicely appreciate that we could nicely preserve the dimension. So now I am really in a very comfortable situation to do my implant therapy. And now I also sent the patient to one of my colleagues, Professor Amélie Mingeot. And maybe I didn't clarify it at the beginning, but I am actually a periodontist. And in Belgium, when you're a periodontist, actually you have to be exclusive. So I'm not practicing general dentistry, and I'm not restoring implants and teeth. So I'm working in close collaboration with our prosthodontic department, and I also work with many referring dentists. So I am doing mainly only surgeries, and all the restorative work I'm going to show today is work from, in the aesthetic zone like this, you will see lots of cases from Professor Amélie Mingeot from our pros department, sometimes other people from the department, or sometimes some referring dentists. I'm not also going to extensively discuss these restorative procedures because it's not my specialty, but you know, of course I would show you the results, the end results of the case. So, it means also that for me, when I plan to restore a patient with an implant, I would never place an implant without discussing the treatment planning with the restorative dentist. This is really, if we work like this in hyper specialty, we really need to have a teamwork. We need to work together. And in this case, you know, I sent the patient to Amélie, and she did like a full aesthetic analysis. In the aesthetic cases, this is what we do. This is really common practice to look at the face, the external, the facial aesthetic, the smile, the lip line, where the incisor edge should be. And this is a patient that already had some veneers. Actually, here, you know, this is some veneers that she wanted to redo. You know, she wanted to have a new smile, basically. So we really did an overall approach here. And this is where we start. We try to set up the goal, see what we have to do, and based on this, you know, for me this is very useful because I can see that now in the implant side we are very comfortable. We have a little excess of tissue, so this is good, and we will be able with the provisional to push that a little bit. We also see that on 11 and 12 we have a little excess, so I know that there I would have to do some minor little crown lengthening. But on the 2 canine, there I have a defect, a soft tissue defect, and there I will do an additive procedure with connective tissue graft. So this is here case that I treated more than 10 years ago. I'm going to show you the long-term follow-up. So we didn't have CBCT yet at that time. It was still the old schedule, so it's quite the quality is not so high, but enough to appreciate that with the socket management procedure, we really could maintain the bone dimension. And here this is actually very safe to place an implant. So this is the live surgery I did at the time. So again, the quality of the movie is not the best, but enough to show that you know, the hard and soft tissue are so nice that it's to my opinion, perfectly safe to do a flapless procedure in a case like this one. You saw that I use like a conventional surgical guide. I mean, I would always use a surgical guide, but at that time this was still conventional. Nowadays, and we will see that this afternoon, I would always do a guided surgery in the aesthetic zone. And after the surgery, I placed just a transmucosal healing abutment. If I have a good primary stability, and if I am in conditions that allow immediate loading, I would also do immediate loading. In this case, we waited a little bit, we waited osseointegration, and then Amélie did this screw-retain provisional crown. And this is how we are after loading the implant. Now, I will, you know, we can do again the aesthetic analysis and see a little what we have to do on the side. So, to come back a little bit to this extraction socket management sequence, but again we will go a little bit more into detail in the afternoon. So this is the baseline situation, and you know, the blue line is the cervical level from baseline. So you know this is the procedure, socket intact, you put the material, you do the saddled connective tissue graft, and then it heals. And basically when it heals, what's happening is that you lose the buccal plate, you lose a little bit of bone, but if your material is non-resorbable or slowly resorbable, you maintain the volume that was inside the socket. But you usually lose, just by removing the tooth, you remove the transmucosal support, and you're always, at the time of extraction already, lose a little bit vertically. But once you will, here, connect again the component, the transmucosal component, you will push again outwards the soft tissue and gain a little bit more. So that's here the different side procedures. So as you see, a little crown lengthening on the 11 and 12. When doing a crown lengthening, you see that I did a flap, I did a little gingivectomy. Here I have lots of keratinized tissue, so I can just remove by a gingivectomy. But when you do that, you need to raise a flap because you also need to do a little osteoplasty. I don't have the picture of that, but you need to recreate the biological space around the natural tooth as well. So it always goes with a little flap. You remodel the bone, and then you go with that. And you see it on the canines. There, I did a graft, a connective tissue graft, with an I coronally repositioned the gingiva with a poach technique. But first of all, if you remember, there was like two big composites in the cervical area. When I do we do general recession coverage, we should always remove all the composites or all the fillings that are there, because we need to have dentin to be able to have an adhesion of the connective tissue. And this is okay if you have like cervical lesion, this is okay if you have like notches, this is actually good because it stabilizes also vertically your soft tissue graft. It's a little bit like the platform switching around the implant, you know, it provides you a kind of vertical stability. So basically, I don't have the detail of the pictures here, but I removed the composite. I had some kind of, concavity, but I drafted it in there. So you have here a little bit more details of what was there, and there the quantity of, especially on this side, the quantity of keratinized tissue was a little bit limited. So this is why I left a little piece of my connective tissue graft exposed, in order to recreate a little bit of keratinized tissue. I'm not going to go into the details of all these procedures, and this is also one of my topic of interest to the recession coverage. It's not a topic today, but here I like to share with you the overall case, and I think it's interesting to discuss these aspects as well. But when you leave your a little millimeter of connective tissue exposed here, you have to make sure that at least 90% of your graft is submerged. Vascular supply, remember, this is always what you have to keep in mind. So this is here, I think after, no, this is the day of the surgery. And you see, the patient after the surgery directly went to my colleague Amélie, and we adjusted the cervical level of the tooth where I did the crown lengthening. And that's something else that is important in implant dentistry, but also in mucogingival surgery, is that our concept is that it's the restorative part that is going to guide the soft tissue healing. The soft tissue, they're going to heal according to the design of the prosthesis or the design of the tooth. So this is important to me, that right after the crown lengthening, she reshapes a little bit, kind of provisionally, because there is a bit of blood, but she reshapes the cervical level in order to maintain and have the tissues healing around that. Because if you don't do that, when you do crown lengthening like that, the tissues, they usually have the tendency to go back. You really need to retain them with a proper cervical level. So this is 1 month after the surgery. Yeah, she was still the ortho treatment on the knees, and then Amélie removed the old veneers, and she did some new ones. And this is here the provisional veneers. And of course, with the provisional, she can still discuss a little bit with the lab technician, where we have to, change a little bit the profile and do these minor adjustments. And this is here the work of the final restoration. So you see that we did a screw-retained restoration of the implant with a zirconia framework, and then the ceramic was mounted on the zirconia framework. What I can emphasize here is the design of the transgingival part. And that's something very important to us. It's the design, we have a design that is narrow transgingivally. We leave some space for the soft tissues. And then, the critical level, the critical zone is the cervical level. And there, of course, we go flared, and it should be as defined by the aesthetic analysis. What is also important, and we will shortly talk about materials as well, the transgingival part is not covered by veneering ceramic. The transgingival part is this pure zirconia that is not glazed. Because zirconia is very biocompatible, and we should have pure zirconia in contact with the soft tissue in order to have a proper interface, to have a proper muco-integration. So you see the design and the type of material is important. And this is here the final result. I'm not sure we have, the overall picture on the screen, because this is cut there. I think we're missing some parts. But I'm not sure, but so this is the before and after. Of course, both my colleagues and the lab technician did an amazing job. This is here the occlusal view. She also had, you know, you remember other problems because she had the resorption in the lower jaw, so she also had some implants in the lower jaw. She also had some endochromes on some roots that could be preserved. So this is here the occlusal view of the lower jaw, before and after placement of the crowns. This is the before and after. Of course, when we see the situation before, yeah, this is so it is when you have glue and braces for so many years. And this is the X-ray, the overall X-ray after the old treatment. The patient smiles again. She was very happy, and she was very proud of her new smile. As you see, she also changed, you know, when you restore a patient like this, you know, like with a new smile, afterwards they usually change everything, you know, change the haircut, change, sometimes even change her husband. But yeah, no, she was happy. I'm kidding here, of course, but she has a new style that was really a new start for her, especially after suffering for 7 years with an ugly orthodontic device. Thanks God we have new solutions now with all the aligners, but this is how it was at that time. So this is the result after 1 year. And then this is the result after 2 years. You see that everything is very stable. This is the result after 5 years. So this is very important to not look only at the gingiva, but to look at the bone levels, you know, and we see that we have absolutely intact bone levels, you know. This is the result here at the comparison between 2011 2017. So after 5 years, I mean, I could even change the pictures, that would be the same. So this is very stable, and this is what we want to say, and this is what we need. I mean, it's good to have successful treatments at 1 year, but you also need a successful treatment here at 7 years. And actually, this is a patient that was in a study, in the socket management study, and I will give you the result of that study later on, but you see we did many measurements, and we look at the buccal bone, you know, the buccal bone plate that is very stable. And I can tell you, I don't know if I have the slide here, that it is very stable over time. After 7 years. So, you know, some people were saying that this socket management technique, we don't have the data on the long term, but I think I'm going to show you here. 8 years here, same. Anyways, I could continue like that. I think now this is more than 10 years that we are following this patient, and this is still very good, very stable, and she is still very happy. And that's the study. So let me go a little bit more into the details. So this is all these patients where we did some publications like some years ago. We looked at the profile, the bone three-dimensional changes, and the soft tissue changes. So these patients, they had impressions, and then we make these impressions numeric, and then we superimpose the data. So we superimpose the scans, the CBCTs, and we superimpose the outlines of the impressions. And what is interesting to see is that, and that we had this data from a long time, is that from baseline to 3 months, actually we lose 1 millimeter. Basically, we lose the buccal plate. But from 3 months to 6 years, or to sometimes 7 years, 6 years is the average, so we can already consider that this is maybe not long-term result, but at least medium-term result. We lose 0.07 millimeters. Basically, we lose 0, you know. Clinically, from a clinical point of view, this is nothing. So, in terms of bone, this is very, very stable. But I come back to the question before the post. We use here a non-resorbable material, or a slowly resorbable material. That was by us. We also look at the soft tissue profile. In all these cases, they were treated with the saddle connective tissue graft. And in terms of the soft tissue profile, it's not here, but it was also very stable, and we had excellent big aesthetic scores. So, yeah, to conclude this, I think the technique is quite reliable on the note. And this is a case that I like to show because we have really the long-term data, and this is important to not only show like short-term results. Well, here is a few cases we discussed this morning already, and all these cases I have augmented or adjusted the quality or the quantity of the soft tissues prior to implant placement, or with a connective tissue graft in the aesthetic zone, or with an epithelial connective tissue graft, a free gingival graft, mainly in the mandible and in lots of the cases in the posterior mandible. So the question now is, do we do that only prior to implant placement, or can we eventually do that later on? Can we eventually do that at the time of implant placement? And this is a concept we are extensively going to talk about this afternoon, because we are going to talk about immediate implant placement. And as you see here with a case, we can also, in some cases, do this connective tissue graft at the time of implant placement, and also have some very stable results at the time. Next question is, do we still have a chance afterwards? Can we still do these types of soft tissue augmentation after implant placement? Well, there I am a little bit shared, because when we do it afterwards, it means that we may have some complications already. And someone is going to talk this afternoon about connective opacity. It's you? Who is going? I don't know who is going to be. I am. Well, yeah, I'm really looking forward to your presentation, and it is actually perfectly complementary with what I'm going to tell today, because I'm not going to talk about complications. You are going to talk about complications, and this is amazing. Because this is a lot more complex, actually, to do the soft tissue management once you have the complication. I want to show you a case here where I don't have yet a complication, but I have in this case a lack of keratinized tissue, but still this is stable. You see on the X-ray, I still have a very good bone level. And in these cases, I prefer to have a preventive approach. And this is a case I implanted myself. And I did pay attention to to preserving the keratinized tissues. I thought enough keratinized tissue, but sometimes you have like a resorption of the keratinized tissue also a little bit over time. And here, when you look, I don't have much anymore on the implant in the premolar position, and I don't have it all on the molar position. But this is typically the cases where after a few years you start to see bone loss, and actually where the muscle fibers are actually pulling a little bit the soft tissue around the implant, and may like open or break a little bit the sealing, the mucosal sealing that I remember is fragile. It's fragile, it's not a strong attachment. So I told the patient, everything is good, everything is fine, but in my opinion, we should optimize the soft tissue right now in order to avoid any further complications. And then, because once you have the complication, then it's going to be a lot more difficult to manage. And the patient perfectly understood. This is a patient that was restored, with, I placed the implant and I directly placed a titanium base. It was an SRA in this case at the time of the surgery. And a lot of the restorative dentist works screw retained, so that's easy for me. I can remove the bridge. And I work here, and as you see, we don't have at all the keratinized tissues here. So here it's alveolar mucosa, and again I have here. Here it's very limited. So same procedure basically. A free gingival graft. I mean, best option to augment the keratinized tissue. This is exactly what we want here. We want the keratinized tissue. There was not necessarily a recession. This is of course a lot easier to do when you can remove the bridge, so this is why a screw retained bridge is more convenient. And this is more or less a very similar procedure to the one where we saw the video, except that now there is an implant. There was no recession yet, so this is easy, but keep in mind that if you have a recession on the implant surface, and maybe you are going to talk about that this afternoon, it's really challenging to cover the implant exposure. I would say it's almost impossible. But in that situation, if you already have a recession on the implant, the goal is not to cover the implant, but it's actually to recreate like a piece of keratinized tissue in order to recreate the hermeticity, to provide a new hermeticity. But here I was early enough, I didn't have yet a recession, and this is the same procedure. And you can see here that after a few months, when she came by, you can really see that the keratinized gingiva is the keratinized mucosa is well integrated. So I come to the end of this first part of the first part. So if we have to conclude a little bit the surgical approach, I would tell that if the conditions of the future peri-implant mucosa is not favorable at the very beginning of your treatment, for example, if you don't have enough keratinized tissue, if you have less than 4 millimeters, if you have a very thin tissues, if you have like a very thin phenotype, especially in the maxilla, I would strongly advise to take care of your soft tissue prior to implant placement. Most often with a free gingival graft, with an epithelial connective tissue graft at the mandible, and with a connective tissue graft in the aesthetic zone, in the maxilla. If we are in cases that are more favorable, it's still time to think about this thickening of the soft tissues at the time of implant placement. And we will further discuss this topic in the afternoon when we will talk about immediate implant placement. Because you will see that immediate implant placement is very often associated to soft tissue management, especially in the aesthetic zone. Finally, can we still do that after? I would say that after you have basically to deal with a failure, to deal with a complication. Remember, at the very beginning of the presentation, I said we're talking today about prevention. So prevention is go for option 1 or 2. Still, it may appear later on that you have like a resorption of the tissues, so we can still do it afterwards, but always better to do it before. Right? Is there any question? Maybe you take the microphone. But thank you to the translator, because I hear you still talking after I'm talking, so I hope you're fine. Yes. It's not working, but I hear you and I can repeat if you want. Okay, so here the question is about substitute to connective tissue graft or to soft tissue graft. I will talk about that a little bit this afternoon. I don't have much experience with this substitute. There is not so many on the market, and we don't have the mucoderm in Belgium, so this is why I don't have experience with that. I have experience with some of the first version of the Gs product. It was oh, I forgot the name. Anyways, it is not as successful as a connective tissue graft. The gold standard, and also we had some international consensus meeting about that. The connective tissue graft is definitely still considered as the best material to optimize the soft tissues, especially when it comes to augmenting the keratinized tissues. I will show you a case, or actually maybe I will talk about some recent studies that were done by Arndt Happe. He's a German oral surgeon, and he has compared the mucoderm, the dermal matrix, with the connective tissue graft. And actually, when you look at the literature, very often they don't compare the substitute with connective tissue graft, they compare it with nothing, you know? So we don't don't compare to the gold standard. But here, the recent studies from Arndt Happe, they show like really interesting results in terms of volumes. It's associated to immediate implant. Of course, this is 1 year result, so this is not long term, so I would still be a little bit cautious, but I will mention it this afternoon. But for me, if you ask me my opinion, still nothing is better than the connective tissue graft.
Yeah, thank you. The last question. Can you share whether your secret when you harvest the soft tissue from the palate, there's no bleeding? No bleeding?
A good anesthesia, you know, adrenaline. Yeah, adrenaline. The thing is, of course, you have the adrenaline effect, but just for a few minutes, so you have to be fast, you know. So usually at the beginning of the procedure, this is still well maintained, and you do a good anesthesia just at the emergence of the posterior canal, you know. You do a block anesthesia, basically. And usually when I start my procedure, I already make the palate numb, because I do the not very nice stuff at the beginning, and then I tell my patient, now you can relax. But just before harvesting, I go for new anesthesia, I mean with a high dose of adrenaline, just for the vasoconstriction. And then I know that I have a few minutes where I'm quite comfortable. But usually, when it goes to the time of suturing, especially when you do sub-epithelial harvesting, when you start suturing, it starts bleeding again. We will discuss a bit the techniques a little bit later with movies, and you will see that at some point it bleeds. So. But it's good that you mentioned that, because something I did not say, and which is really important for the comfort of your patient, is that when you do this free gingival graft, you know, when you harvest the connective tissue and the epithelium, we have to be aware that we are really creating a second intention healing in the palate. And I'm telling my patient, and I can tell you, to me this is This can be the most painful procedure in dentistry. I mean, you can do bone augmentation, you can do sinus lift, they will swell for sure. But most of the time, if you provide at least the proper painkillers afterwards, the pain is not so high. But with this type of wound healing, it can really heal like an aphthous, you know, and this a big aphthous, depending on the size of the graft. And this, not in every patient, and I would say that from my clinical point of view, that maybe in 1/3 of the patient, this can really be highly painful. And even if you go for like step 2 painkillers, this is sometimes like the worst experience for the patient. And I hate when my patient comes back and I have like an awful experience after, you know, after being in my dental chair. So now I systematically do a palatal plate, you know, a palatal plate. So I take an impression before. I do like an orthotrill palatal plate to protect the wound. And on the one hand, it's protecting the wound and it significantly decreases the post-operative pain. And you know, you then have also something, because this is also a region that is highly vascularized and you can definitely have post-operative bleeding. And this is also a plate that can play a role of hemostasis. So you have, and then you tell your patient if it bleeds. Sometimes it bleeds when they go to bed, when they are in a lay-down position, and they can just, you know, put it and press a little bit with the thumb, and this is very useful. Honestly, I don't really give the choice to my patients. They need to have this plate. Others will, you know, work with collagen sponge or other types of stuff, suturing. Yeah, I mean, there is not only one recipe, but my recipe is the palatal plate. There was other questions? Yeah, there? There, the microphone would be good. One here.
Xin chào tất cả quý thầy cô và các đồng nghiệp. Xin cảm ơn giáo sư có một bài giảng, một bài thuyết trình rất là hay, và bản thân tôi học hỏi nhiều thứ. Tôi xin có câu hỏi. Giáo sư đưa những cái thuyết là có nghĩa là những cái không có cái nếu sự hóa thì ghép, nhưng cũng có một số quan điểm người ta thấy là không có nước sự hóa, dùng bên trong thì nó vẫn không có tụt nước. Ở bản thân tôi thì thật ra tôi cũng làm trên 20 năm, tôi cũng theo dõi có những ca mà nếu sự hóa nó ít nhưng mà nó vẫn không tiêu, nó vẫn tốt. Và tôi cũng theo dõi thì có những kinh nghiệm. Tôi nghĩ là ngoài cái nước sự hóa nó cũng tác động, nhưng mà cái cách mà đánh răng nó rất là quyết định. Như vậy ở Việt Nam chúng tôi thì thí dụ tới mà tôi ghép cái dấu sự hóa để lấy một cái vị trí thứ hai để mà ghép vô thì nhiều bệnh nhân họ sợ, mà không phải đơn giản lấy vô rồi nó chảy máu. Có những lúc mà chảy máu không phải cơ địa nào là trong cơ địa nào. Như vậy theo triết lý của giáo sư là đem tới sự hoàn hảo quá mức. Nhưng mà theo tôi xin hỏi giáo sư, có nhất thiết của mình đem đến sự hoàn hảo mà bệnh nhân họ đau đớn. Nhưng mà cũng có tác giả là, và theo bản thân tôi thì không, nhiều lúc không nếu sự hóa không đủ, nó vẫn không tiêu xương, nó vẫn không tụt nước. Thì xin giáo sư cho biết cái triết lý theo cái triết lý của giáo sư thì quá hoàn hảo rồi, không có cái nhất thiết là ca là mình cũng làm là ghép vô sự hóa để cho đủ không. Mà dư luận trên thế giới những cái tạp chí của cũng rất là có tác giả là không, nhiều lúc không có nước sự hóa không đủ, nó vẫn không có tụt nước. Xin giáo sư cho ý kiến.
There are some concepts that they would like the Kevin tissue, the gum is still stable and the bond, and the gum is not receding. And the question is, should we check with the profession, with the patient careful, bleeding, with the keratin tissue improvement?
So, do I understand correctly that we are questioning here the morbidity benefits of the procedure?
And because he said that in his experience, and also there's a concept that they said that without the keratin tissue, especially in the inferior region, the gum is still stable. We don't have receding, and the bond is still stable. And yeah, how about?
I know this is a controversial topic. I know that for many years there were strong defenders of saying we don't need a keratinized tissue to have long-term stability of the implant. I'm not necessarily talking about the soft tissue, the recession, but I'm talking about the health of the implants. I mean the peri-implant health of the soft tissues and of the bone. This is why I said this may remain a controversial topic, but the recent consensus, you know, in 2017, it was in Chicago, we had a joint meeting with the European Federation of Periodontology and with the AAP, the American Academy of Periodontology, and we came with this new classification. And we also, I was in the group of peri-implant soft tissues, there was a group about that, and we came on with we don't have the evidence that we have better survival when there is keratinized tissues, but there was a common agreement that it's preferable to have keratinized tissues around the implant. But you're right, it remains a controversial topic, and in my opinion, just because we know, and for that there is the evidence, that without the keratinized tissues there is more plaque, there is more inflammation, and there is also more patient discomfort. But we can discuss it, this is true. I hope it's answering your question.
Kính thưa giáo sư, kính thưa toàn thể quý vị, thì có thực hành ở Việt Nam thì có cái đúng là văn bản option của giáo sư thì tôi rất là thích cái đoạn thứ ba, cái việc là khi nhìn sang cái implant thì Việt Nam có hiện tượng là viêm quanh implant và nó tụt cái nước và nó mất cái nước sinh hóa, mặc dù mình đã rất cố gắng ghép xương và màng, tuy nhiên sau một thời gian có hiện tượng viêm quanh implant và lột các ven implant, thì vấn đề ghép cái mô sinh hóa của bà thì giáo sư giúp cho là cái kinh nghiệm để mình xử lý cái bề mặt implant, cái vùng lỗ như thế nào trước khi ghép và nó hiệu quả cao hơn. Thứ hai nữa là cái trong chỉ định trong trường hợp nào thì mình nên ghép và trong trường hợp nào thì mình cũng chưa cần nên ghép, giống như là một ý kiến của bác sĩ là bác sĩ Thành là con giáo sư.
In case that the periodontitis, what the technique to clean the implant surface and the indication and when we need to graft and when we need not so really sensitive.
Yeah, that's another topic. It's a long topic. Well, how to summarize that in a few words? Yeah, definitely peri-implantitis is a problem, and I think nowadays we don't have a perfect solution. So this is why it's better to prevent it than treating it, because treating it is, I don't want to say it's almost impossible, it's almost impossible to reverse it completely. It's not as efficient as treating periodontitis, you know? And we have to know that from the very beginning. And this is why also we don't extract teeth that are still preservable to place implants. Oh, that's another topic. When we have a peri-implantitis, we need to look at the type of defect we have, and we need to look at the regenerative potential of the defect. You know, we may have a crater with still bone walls that is more favorable. We need to, but if we have almost an horizontal loss, it's like a non-vulnerable situation to regenerate. So we need to look at the anatomy of the defect. We need to look and to understand also, and that's maybe the very first step, why. We need to try to understand why we have a periimplantitis. This is of course multifactorial. Some, you know, this can be smoking, you know, this can be like cement fusion that induced an early bone loss, and then you had a secondary infection of the surface of the implant. This can be also an implant malpositioning, you know, and we need to basically change something in the equation before treating. We have to re-establish like the balance. We have to remove the risk factors. Some we can, some we cannot. If it's an implant malposition, then it's difficult. We also need to, we have to decide if we treat it surgically or non-surgically. When it's usually like early periodontitis, when it's the early step, you may try to work with a non-surgical approach. I'm not a huge specialist of periimplantitis, but there is a protocol that was suggested by the group of Santiago in Spain. Antonio Linares, if you may know, he recently published some very interesting data about the non-surgical therapy to treat periimplantitis with basically going with ultrasonic device, removing soft tissue with ultrasonic device, and combining with antibiotherapy and specifically metronidazole. But I invite you to read maybe the papers. If we have a more significant defect, you may consider a surgical procedure. And when you do a surgical procedure, you can either go soustractive or regenerative. And if you go soustractive, basically the idea is to bring the tissue down. You know, it's like periodontal surgical approach, or you go resective or you go regenerative. It's a little bit the same concept. And it depends on the anatomy of the defect. You know, if you have a regenerative potential, you may go regenerative. If you don't have a regenerative potential, you know, this is the type of defect, then you go soustractive. If you go soustractive, to my opinion, still the best option is to go for an implantoplasty, to recreate, you know, what the exposed part of the implant, you basically polish it. But it's a little bit of a mess when you're doing the procedure, that's also true. And if you go regenerative, the challenge is to clean the implant surface. And there is many different protocols, but it remains a challenge on the rough surfaces. And this new electric device, you know, may be an option to with the galvanic current, you know, to clean the surface. I mean, there is a new data that sounds interesting actually. Otherwise, you know, there is many publications. This can be cleaning with brushes, combining chemically with antibiotics and so on. But really, the cleaning of the surface remains a challenge. But this is not only about cleaning the surface. This is also about the regenerative approach. And there, depending on the defect, you go with you know, biomaterials, membrane, eventually endogain. But what I'm saying to my patient is that the success is never guaranteed. So this is why it's better to preserve it. It is a long answer. I mean, it's really a difficult topic to discuss in 5 minutes like that. It's not really the topic of today, but I try to summarize my opinion about that in a nutshell. I hope it's answering your question.
I have two questions. The first one, in case we need multiple surgery, how long should we wait before we have this?
In case we what?
We need multiple surgery, so we will have to do the surgery again to graft, do the free GG graft. So how long we should wait before we harvest the palatal?
Okay, I got it. So yeah, in case we have several defects and multiple recessions, blah blah blah, how long do you have to wait to go again to the palatal area? I usually wait, you want to have a proper soft tissue healing, but with a tissue that is mature, I would wait 2 months. But completely based on clinical experience, I would say.
And in case of we need large compensation of soft tissue, do you consider using the tuberosity connective tissue?
Yeah.
Yeah, and
but it depends for what, you know. If you need a long graft to augment the keratinized tissue in the posterior region, the tuberosity is usually not enough. The tuberosity is a very good quality of tissue, and we will talk about that in the afternoon, because to me this is an excellent harvesting site for immediate implant when we need to do a graft combined to immediate implant, because we don't need a graft that is too large, and there it's for me the option number one if we have a tuberosity available. Yeah.
can we apply the same concept and the center concept with the tuberosity?
You cannot, because you don't have a graft that is long enough. But we will talk a little bit about that also in the afternoon, and you will see that this saddle concept, now it's a concept that I have reduced doing, because we need quite a large graft. And I still do it when it's very unfavorable, when we have, you know, like really significant recession, when it's very unfavorable. But more and more, now I'm doing the socket management, and we're going to talk a bit about socket management. I do it with, I just put a collagen plug on the top, you know, I feel with the material, and I put a collagen plug, and I let it heal like that, and I augment my soft tissue at the time of implant placement. Because then you need a connective tissue graft that is less large. Because I'm also continuously thinking how to decrease the morbidity for the patient. That's clearly a topic here.
Dear Professor.
Yeah.
Thank you for your presentation. I have two questions. The first question is the case before the last case, the female take a brackets orthodontic. Okay, and I have a question for this case is I see that you do the veneers and prosthodontic on the implant, and so the problem is black triangle.
Is what?
Black triangle.
Yeah.
Yeah, and I want to ask more about this. How do you take the prosthodontic to solve the black triangle? It's very beautiful.
To me, in this case, that was not too much of a challenge, the black triangle, you know, especially because this is a case where
the mixture of teeth now, 1, 2, 2.
Yeah, but you know, this is a case where we had to do a little bit of chrome lengthening, so we basically brought a little bit the cervical level a bit higher. So that was, to me, that was not so challenging in terms of black triangle. But for the papilla, in general, I mean, when we have like a significant papilla problem, you we know this is, we know that we don't regenerate the papilla just with a connective tissue graft. It doesn't work, basically. And let's say that not the secret, because it's not a secret, but the solution for these black triangle problems, it's a kind of multidisciplinary treatment approach. It depends the cases, of course, and it's more complex when it's like virgin teeth, I mean when they don't have restorative parts and so on, but to me this is a combination of an orthodontic treatment, bringing the tooth, extruding the tooth in order to extrude also the proximal tissues. This is mucogingival surgery reinforcing of course, the gingiva, and you know when you reinforce the gingiva at the base of the papilla, you know, over time we see that it's actually, I mean, improving a little bit. And the third thing is to work with, it's a prosthodontic approach. I mean, it's also to compensate some of the remaining part of the black triangle, I mean, with the restorative part, and try to look at proportion and eventually do a bit of crown lengthening, you know, crown lengthening to bring the cervical line a bit higher. But in this case, that was not, I mean, it was just filled with the restorative part.
Chị đã còn câu hỏi gì?
Who is asking the question? Yeah.
Cho anh hỏi là cái tỷ lệ thất bại khi mà ghép nấu rời và làm gì mà để em có những cái gì mà để làm giảm cái tỷ lệ thất bại? Em có.
Failure rate of the free gingival graft. Honestly, if you do it properly, it always works. Because this is a type of graft that has a full vascular bed. So the risk factors, I mean, what could lead to that can be different things. And sometimes it can be very stupid. Huh? Patient selection. If you have a smoker that smokes like one pack a day, this is not a good candidate for that type of procedure. So usually this type of procedure, everything that is related to tissue regeneration, whether this is bone regeneration, whether this is soft tissue regeneration, they should not smoke. Don't, you know? Another thing is the vascular supply. You know, you need to have a proper vascular supply. And for a free gingival graft, the vascular supply should be, especially around the implant, this should be 100%. Don't try to cover your implant. On natural teeth, it's a little bit different, but it is very difficult to treat recession with this technique. So the main goal of the technique is to recreate keratinized gingiva, and for that you just put the graft on the periosteum, on the vascular bed, so the vascular supply. Then, sounds very stupid, but put your graft on the correct side, the connective tissue graft on the vascular bed, not the epithelium, because the epithelium is a barrier and then you would have necrosis. You can also don't leave it exposed freely in the air for hours. So when you harvested it, you put it in saline. You know, makes sense, huh? But don't dry it. Thickness should not be too thick. I mean, it should be like 1.5 millimeter, maximum 2 millimeter, because the thicker, the more difficult it would revascularize. Then, suturing, stability of the graft. So the muscles insertion should be properly detached and away from the graft. You should not leave any muscle tissues under the graft, otherwise it's going to move, it's not going to be stable, you will have micro movement and you will not have a revascularization of your graft. What else? Yeah, in these cases, properly also stabilize the flap apically, because if you don't do that, if the flap goes over the connective tissue graft, even though the epithelium is kind of barrier, you may have a reattachment still of the muscle fibers on the top. So this is very important to stabilize that. And of course, apply like microsurgery principles, be delicate. I mean, of course, if the periosteum starts to be bended, detached, it might be a problem. Yeah, I think this is more or less what I'm thinking about. But normally, this is a type of graft that is very reliable if you respect properly all the different steps, and if you do a proper patient selection, of course.
Xin hỏi chị còn câu hỏi nữa không ạ? Okay, if question.
We continue?
Continue.
Yeah?
Ask one about.
No, we still have part 2. But I can be flexible. You tell me when we have to stop, but I suggest we still have a bit of time before lunch, right? Yeah?
Các chị muốn nghe nữa hay là kết thúc ở đây ạ? Dạ thì finish this session this morning. I'm today at
Okay.
Yeah.
Already lunch break. That's fine to me.
Xin cảm ơn các chị. Vậy thì chương trình buổi sáng chúng ta kết thúc, chúng ta sẽ ăn trưa và chúng ta sẽ quay lại vào lúc 14 giờ.